I was amused with Dr. Gaurav's introduction. He said she is very comfortable with CTR. Makes me sound as if I create complications all the time. So anyway, realistically speaking, plunging into any irretrievable catastrophe is not at all an impossibility for even a very modern, efficient cataract surgeon. And towards this end, the capsule tension rings is like having an irretrievable and a consistent strategic plan behind. Getting rexes is as critical in a subluxated lens as in a premium IOL segment, and believe me, it gets to be quite a challenge when the zonular support is inadequate because of the lack of tangential forces acting in the DEHIS area. And then you need to do a good hydrodissection because it's critical that you loosen the nuclear fibers, which will enhance the ease in rotation and not enlarge the dialysis during the phacoemulsification process. Note the tremulousness of the lens, and here the CTR is being dialed in through the center, the side port, as you can see, and you have to do it gently. You have to constantly see that the anterior chamber is all the time stable, because the anterior chamber tends to shallow, you will find that you're increasing the area of dialysis, and you will find that the CTR, by its own circularity and its configuration, slips into the capsular fornix, and there you go on with the phacoemulsification as it's happening. You need to do it a very zonular friendly approach. Keep doing the surgery in the pupillary plane. Keep it. Sometimes even supracapsular phacoemulsification is acceptable because the bag tends to be very lax in these situations, and you need to do as carefully as possible with as minimal turbulence as possible. As far as the stripping is concerned, it's quite a tedious, laborious affair because the fibers tend to get ensnared by the CTR, which is there in the capsular fornices, and you need to exert a consistent tangential force centripetally and gradually get all these fibers out, and we have to keep going back to different segments, and finally the lens actually enhances the stability if placed optimally. This is another case, a cold case as I would call, where you know that the lens is already tremulous, and it's just another simple case where a CTR is being planned. This is a rigid pupil, a pseudo-exfoliative eye, and getting rexes in a subluxated lens is quite a trial, and even a high-end viscoelastic helps in keeping the anterior chamber stable. You need to do a good hydrodissection in 1 odd quadrants. Sometimes even injecting a viscoelastic will create a plane for inserting the CTR. In this situation, I have inserted the CTR to the main port, but by and large I would avoid it because you won't want any kind of wound distortion to occur when you are going to the main port, because this could shallow the anterior chamber and could increase the area of dialysis. And you should see that you insert the ring in such a manner that it is going towards the area of dialysis, and the ring itself buttresses and pushes back the area of dialysis and gets inserted carefully. As far as the phacoemulsification is concerned, you need to keep your parameters low, lower the bottle height, lower the infusion rate, whichever way you're going. And in a soft cataract, it's not much of a challenge, but in a hard cataract, doing with lowered parameters definitely slows down the surgical procedure. Removal of these fragments is also quite a challenge. One, it's a smaller size pupil, but the bag is so lax, in spite of the CTR, which is giving the stability and circularity to the bag, you'll find that these fragments tend to keep slipping deeper into the capsular fornices, and sometimes you need to mechanically bring out these pieces forward and then gently phacoemulsify it. And when it comes to the last fragments, you need to really keep down your parameters low because the bag is quite lax and tends to be quite buoyant, and you could end up with a PC tear. Again, as I had earlier alluded to, this kind of cortic stripping needs to be done very carefully. It could even be likened to a windscreen wiper motion when you go right from one end to the other, loosening, and be very patient to go about it, because you need to also remember that the posterior capsule is lax and could any time you could end up with a PC rent and a huge disaster. This is another situation wherein the phacoemulsification is nearly completed, and there I get the whole nearly 4 or 5 clock hours, and I'm You know, this was so unexpected. It was a routine cataract surgery with a large pupil. All I do at this point of time is to stabilize myself and inject enough viscoelastic to deepen the bag and push the dilaced away, area well away, as you can see. Much of the cortex is already loose and hanging around. And again, I would go in through the side port. You can see, I'm sure the way I'm showing the CTRs, it's going to be easy for a young ophthalmologist sitting in this audience, that all that you need to see is that the anterior chamber is constantly stable, there's enough viscoelastic, the bag is well inflated, and then you gently dial in. And if there is any resistance, you need to change your angle of approach when you're directing the CTR, because you shouldn't go through the capsular fornix and create a rent in the equatorial area. And in this scenario, however, the cortical fibers are coming out easily because the surgery most of it had gone on without before the dialysis occurred. And the final message here is, when you implant the lens, you implant it in such a manner, of course the bag should be well inflated, but the haptic should be directed in the area of the dialysis. So besides the capsule tension ring, the haptic also keeps the dialyzed area well away. This is a situation, iris coloboma and lens coloboma. My message here is, there is no actual dialysis here, but you should expect weakening in this particular area. So when it comes to the cortical stripping, it has to be so gentle and swishing movement, and this is the area where you would strip the cortex, because this is the area where there's probable weakness. And here I'm showing you how the injector, I'm inserting the CTR. The essence here is, although there's not a dialysis, we need to keep in mind that this is a situation where it can go into zonular weakness, and placing a CTR would only enhance the stability of the intraocular lens. This is a case where, when probably we all wind up in our minds, go on to the next case or plan the work of the day. The surgery is nearly completed, and this was actually my last case of the day, and now the IOL is inserted, and I've actually disconnected from the whole process. The message for you here is, we could end up with a dialysis at any point of the surgery. Probably that is why every step of phacoemulsification need to be very cautious. I am in the process of removing the viscoelastic, and sometimes we get overzealous trying to rotate the lens so that you remove the viscoelastic which is behind the bag, which is what I've been trying to do, and everything was all right when just suddenly a catastrophe happened, and there you see I've created dialysis by catching on the rim of the capsule. Again, I had to calm myself down. All I have to do is inject enough viscoelastic so that I really deepen the AC, push the dialyzed area away, and actually gets you into a complacent feeling that probably you don't need anything at all, but there the airing dialysis is there. So now what I would like to do is, first and foremost, once the AC is deep and well formed, I would direct the haptic in such a manner that it pushes back that area of dialysis, and that ensured, in my earlier days of surgery, probably I would have actually taken off the visco and hydrated and come out. But now I have enough sense to understand that this should not be neglected. And with the intraocular lens in place, I inject a CTR here. It tends to be a little bit more of a challenge, placing a CTR with the intraocular lens in place. But definitely, it's worth doing rather than having an unhappy patient with a decentered lens later on. And then once this is done, inject the viscoelastic and then deepen the anterior chamber, but you're more confident that you have done the right thing to the patient, and further dial the haptic in such a manner that it is again in the area of dialysis. In spite of all the precautions and all the care that we do, this zonular weakness is often a progressive zonulopathy, and you find that although in this particular case we had implanted the lens properly, we had placed a CTR, the patient came in much later with the lens subluxated, the CTR in the anterior chamber, and at this point of time we need to become realistic and resort to creating a tunnel incision and get the whole piece, the CTR, the ring out, and plan a scleral fixated IOL. I would like to conclude stating that as far as subluxated lens, CTR is the first step to go when you have just a few clock hours of dehiscence. But then the iris hook, the CT segment, the modified CTRs all help us in getting the bag stable, centered, and completing a surgery uneventfully.